Yeah, well, as I said, identifying a clinical complete response, which is a normal endoscopy, negative imaging, doesn't correlate with pathologic complete response. Probably it's accurate less than half the time, so that if you rely on that, you're going to be leaving residual disease in 50% of patients. For adenocarcinoma patients, pathologic complete response rates are relatively low, so there's usually a role for surgery in the vast majority of those patients. And with the exception would be medically inoperable or medically unfit patients. If they have clinical complete response, we might opt to observe those patients. The other exception is squamous cancer of the esophagus, which has a higher pathologic complete remission rate with chemoradiation, up to 50% or higher. And that's a group that we might feel more comfortably observing without upfront surgery. One of the problems with delaying surgery is you increase operative complications. And there was an interesting presentation here at ASCO that looked at a retrospective review that delaying surgery in adenocarcinoma patients after chemoradiation might have a detrimental survival impact, not just factoring in the surgical complications, but there was a trend towards inferior survival in patients that had their surgery delayed beyond 60 days. A lot of interesting speculation about tumor repopulation, immune-mediated mechanisms, but I think with the exception of squamous cancer of the esophagus, most adenocarcinoma patients, even if with a clinical complete response, we would consider surgery given the low rate of clearance of the tumor that we achieve with a neoadjuvant treatment alone.